Delirium. Delirium is actually altered mental state, a toxic confusional state. There will be drowsiness, disorientation, global impairment of cognitive function, clouding of consciousness, muddled thinking, motion at night, hallucinations, disturbance of emotions, agitation, fear, depression, or psychomotor changes, hyperactivity, restlessness, repeated plucking and tossing, and tremors. Question which comes as scenario: a middle-aged person who suffers from hypertension and renal insufficiency, means it has some medical illness, is hospitalized this last few days and only recently has been noticed to talk irrelevant, appears disoriented in time and place, agitated, and has lack of concentration. He gets auditory and visual hallucinations. It is signs of delirium, altered mental status. Delirium is defined as acute cognitive impairment, precipitated by insult such as illness or surgery. Here are some interventions to prevent delirium. I made a mnemonic such as bed MSS, B for bowel and bladder. We have to assess, treat constipation and avoid urine catheters. We have to treat environment, limit ward moves, dehydration, then medication, avoid medication, culprit drugs, sleep disturbance, noise reductions. We have to do it. Then sensory impairment, screen for visual or hearing impairments. Then here comes the causes of delirium. I made mnemonic in local language such as Madni, MD, and I am for metabolic hypoxia, CO2, narcosis, hyperglycemia, electrolyte imbalance, and hepatic encephalopathy. And drug poison, alcohol, salicylates, penicillin, digitalis, and tricyclic antidepressants. Nutritional deficiency, thiamine, niacin, proteins. Endocrine, we have thyroid, parathyroid, adrenal, and pituitary. Intracranial, we have the epilepsy, trauma, meningitis, migraine. Under, we have the post-op cases such as sleep deprivation, systemic infections, and febrile delirium. Clinical features we have discussed. Then there come the investigations. We do in essence ABC, glucose, urea, TFTs, LFTs, RFTs, ABGs, urine and electrolyte, CSF, and brain EEG, brain CT scan, MRI, chest X-ray, and ECG. Then comes the management: withdrawal of all drugs, careful nursing, dehydration, antibiotics, nutrition, prevent pressure sores, well lit quiet environment. Special treatment we have to give atypical antipsychotics, olanzapine, quetiapine in all cases of delirium except delirium tremens. In delirium tremens, we give benzodiazepine and treat underlying cause. And here comes the how to make diagnosis of delirium. The 4A test. 4A means the first A correspond to alertness. It is a normal, then we have to give 0. Mild sleepiness less than 10 seconds, then 0 marks. Then 4 question abbreviated mental test. We have to ask patient their age, date of birth, place where they are, and the current year. 4 question we have to ask: if no mistake 0, 1 mistake 1, if greater than 2 mistake, then we give mark 2. Then attention, we have to ask the patient to tell the months of the year in backwards order. If he achieves greater than or equal to 7 months correctly, then mark 0. Start but score less than 7 months, 1. Untestable, mark 2. Acute change, these paranoid hallucinations for the last 2 weeks and still evident in last 24 hours. If no, then 0. If yes, then 4 marks. If greater than 4, if 0, then delirium or cognitive impairment is unlikely. If 1 to 3, then possible cognitive impairment. If greater than 4 or equal to 4, then possibly it is delirium and cognitive impairment. The maximum possible score of 480 test is 12.